Welcome everyone to our Research Connect series. My name is Marwa Sadat and I am a CDTRP trainee since 2022 and I'll be facilitating today's webinar. So just a quick background about myself. I'm a second year master's student in the lab of Dr. Ian Rogers at the University of Toronto, and I'm studying ex vivo organ perfusion of the mouse pancreas and using it to model type 1 diabetes. So first, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Den, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I'd also like to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. I also encourage you to write your own land acknowledgements in the chat box. We would also like to acknowledge Takeda, AstraZeneca, and CIHR, without whose generous support we could not host these sessions. So before we dive into the main event, I will pass it to Erica for some general CDTRP updates.
Thank you, Marwa. I only have one announcement for today, and it's the save the date for our annual scientific meeting. This year's ASN is less than 1 month away, and we will be in a hybrid format with the in-person component in Montreal, Quebec on December 5th and 7th. Registration is still open, and you can register on our website, and I'll put a link in the chat box really shortly. Thanks.
Thank you. So before I introduce the speakers today, I just have a few housekeeping notes. So today's session is recorded and posted on the CDTRP website and YouTube channel. And during the presentation, please keep your mics off. And if you have a question or comment, you can raise your hand with the raise hand button or type them in the comment section. So I'm pleased to introduce our presenters today, Drs. Mary Ott and Charles Weijer. Dr. Mary Ott is an assistant professor in the Faculty of Education at York University. She holds a research appointment in the Center for Education Research and Innovation, Schulich School of Medicine and Dentistry at Western University, with the expertise in qualitative methods for health sciences research. Dr. Ott led the analysis for this qualitative study exploring stakeholder perceptions of the ethics of normothermic regional perfusion and the implications for maintaining public trust in organ donation and transplantation. Dr. Charles Weijer is a professor of medicine, epidemiology, biostatistics, and philosophy at Western University in London, Canada. Charles is an internationally recognized expert in research ethics. His publications on the duty of care in clinical research, the ethical analysis of study benefits and harms, and empowering communities in research have been broadly influential. From 2008 to 2013, Charles co-led a collaboration that produced the first international ethics guidelines for cluster randomized trials. Charles's current work explores the ethics of research involving imminently dying patients and ethical issues in organ donation, including the use of normothermic regional perfusion. He held the Canada Research Chair in Bioethics from 2005 to 2019. And in 2014, Charles received Western's Helmuth Prize for Achievement in Research. And in 2016, he was elected to the Royal Society of Canada. So we are all very excited to hear from you both, and I will send it over to you now. Thank you.
All right, thank you very much. I'm just gonna share my screen here. All right, can you see that first slide?
Yes. Yeah.
Great, thank you. All right, well, it's a real pleasure to speak to you today. You know, with CDTRP, I really feel like I'm among friends, and this was work that was sponsored by CDTRP and Trillium Gift of Life. So it's a particular pleasure to speak to you on how trust in normothermic regional perfusion is built on an ethics of care, an interview study of stakeholders. And as you've heard, I'm going to be co-presenting this today with Dr. Mary Ott. And Dr. Ott led the interviews and led the analysis on this. And Both she and Lorelei Lingard have been fantastic partners on this project. Work like this, as you all know, takes a team, and I'm very pleased to see other members of our team on this project here, including our amazing donor family partner, Lori Blackstock, as well as Nick Murphy. I hope you both will join in on the discussion period as we discuss this, I think, important work. So as I mentioned, our research team was funded by CDTRP, thank you, and Trillium Gift of Life back in July of 2021 to explore ethical issues in a new perfusion technology and organ donation called Normothermic Regional Perfusion. So I'm just going to say NRP because that's a lot easier for me. So our project had two work streams. The first was to perform a scoping review of the ethics literature in NRP. And the second work stream is to conduct interviews with key stakeholders, including organ donor family, organ recipients, health providers, and members of organ donation organizations. So today, Dr. Ott and I will be presenting the results of our interview study. So my job here is I've kind of got the easy job today, and that's just to sort of set the stage. And so I'm just briefly going to address a few questions. What are the pathways to deceased organ donation? What is the potential role for NRP? And just very, very briefly, what ethical issues with it must be addressed? So, as you know, there are two different pathways to deceased organ donation. There's donation after death determination by neurological criteria, what we used to call brain death. And then there's donation after death determination by circulatory criteria, what we used to call DCD. So let's have a brief look at each of these two pathways. So in donation after death determination by neurological criteria, death determination involves confirming permanent cessation of brain function using clinical criteria and, when required, additional neuroimaging. The continuation of circulatory and respiratory support throughout the death determination process and beyond helps to ensure that organs for transplant are well perfused and protected from damage. However, given that brain death is rare, donation after death determination by circulatory criteria was introduced to address the organ shortage. So let's talk about that. In donation after death determination by circulatory criteria, patients with a poor prognosis undergo a planned withdrawal of life-sustaining measures and progress to circulatory arrest. Death determination occurs following a 5-minute hands-off period to confirm that cessation of circulation is permanent. Unlike donation after death determination by neurologic criteria, circulatory and respiratory support is withdrawn here. And this is a really key difference. And this means that organ perfusion and oxygenation is interrupted during the dying process and the hands-off period. Now, the consequences of this are really substantial, as not all organs may be suitable for transplant, and for those organs that are used, post-transplant outcomes for recipients may be poorer. So, a novel technology called NRP restores regional circulation to organs after the determination of death using what's called extracorporeal membrane oxygenation. In other words, a machine that both adds oxygen to the blood and circulates the blood. The hope is that this will reverse ischemic damage and increase organ quality and retrieval rates. So there are two types of NRP. The first type is called abdominal NRP, and it restores circulation to the abdominal organs. So the vasculature is ligated or blocked at the diaphragm to prevent flow to the brain. The second type of NRP is called thoracoabdominal NRP, and it restores circulation to organs in the chest and the abdomen. So here, arterial supply to the brain is blocked at the neck to prevent resumption of circulation and the theoretical risk of reanimation of the brain. So a major difference between thoracoabdominal NRP, the second type, and abdominal NRP is that in thoracoabdominal NRP, after 20 to 30 minutes, the heart starts to beat again spontaneously. And as a result, the ECMO pump, the perfusion pump, can be turned off. Okay, so NRP is a promising technology. It's widely used in Europe and a number of centers in the United States. It's not currently used here in Canada. There's observational data that supports improved organ function and better transplant outcomes, but there have been no rigorous randomized controlled trials that have been conducted and reported. So NRP also raises difficult ethical issues, and I just want to very briefly go through 4 of these. First, the donor was determined to have died based on circulatory criteria, or the donor was declared dead based on circulatory criteria, meaning that their circulation has stopped permanently. So one of the problems here is that the resumption of circulation seems, at least, to potentially undermine the determination of death and thereby the dead donor rule. So second, while unlikely, the potential for reanimation of the donor's brain through the resumption of brain blood flow via collateral vessels or a failure of surgical safeguards or anatomical variants raises concern about donor safety. Third, there are questions as to whether specific consent for NRP is required in the organ donor process. And if consent is required, what information do families need to know? And fourth, and finally, and I think in a way most important, how can NRP be adopted in a responsible way that will preserve stakeholder trust in the organ donation system here in Canada? So while a variety of approaches are required to address these concerns, to date, qualitative research has not sought stakeholder input on questions of consent and stakeholder trust. And so to better understand the perspectives of key stakeholders on NRP, associated ethical issues, and the potential impact on trust in organ donation, we undertook an interview study. Okay, over to you, Mary.
All right, thank you for that. Setting up the problems and the questions, Charles. I'm going to share my part of the presentation now. Right. Can somebody just give me a shout out quickly that you can see this?
All good.
Thank you. All right, so let's personalize this a minute. And I want you to think about what we mean by stakeholders. So you might have overlapping roles, but place yourself in the center of the circle of care for donation and transplantation. If you're a living donor, an organ recipient, a family member of a deceased donor, or someone providing direct forms of care to these groups. All right? Place yourself in the next circle if you support or interface with this inner circle of care and or with the public. Place yourself in the next circle of influence if you've become a public-facing donation advocate. And place yourself in the outer ring if you're a member of the public with no lived experience of the need for organ donation and transplantation. So we interviewed 29 participants, many with overlapping roles in those following groups. But note that our definition of care provider was broad to be inclusive of critical care physicians and nurses, spiritual care and social workers, importantly, donation coordinators, which wasn't something we intended. We didn't conceptualize donation coordinators as care providers at the beginning of this study, but family members told us that they saw the donation coordinators as providing care to them in their donation journeys. And of course, also included the perspectives of a transplant surgeon and transplant physicians. So as Charles showed, we gave all participants the same set of information and diagrams that he just shared with you about the purpose and the process of NRP. And we presented to them the ethical questions that he raised as well. And so our interview probes were designed first to ask how they viewed the potential contradiction to the dead donor rule. Second, whether they found the issue of the heart restarting in TA NRP, that's the chest and abdomen form of NRP, to be problematic. And finally, if they had any concerns, ethical or otherwise, regarding surgical clamping to vessels to prevent brain reanimation. And what we found was consistency in the ethical standpoints that participants took on all of these issues across stakeholder groups. So that's a very strong confirmatory finding. For example, they told us that regional circulation does not violate the dead donor rule because the person is dead. They're not going to come to life again, or if they did, they'd be so damaged you wouldn't want them to. Because if the damage is irreversible, if the person can't recover, that's the key thing. And because it's really about the cessation of all brain function. After all circulation has ceased, and then there is the mandatory 5-minute hands-off period, that time and that injury to the brain during that time is felt to satisfy the criterion of irreversible cessation of brain function. We found that they did not see the heart restarting as something that would impact their trust in NRP or in organ donation. Because they said, yes, the heart has started beating again, but it's beating because of this, the artificial circulation. It's not beating because the brain is telling it to beat. The brain has ceased functioning completely. I think there are protocols and ethical walls set up, so there's no mistake. We know why the heart is beating if they do chest and abdomen NRP. And ethically, as long as it's explained well in the consent process as to what's happening, then I think it's really up to the person who's making that donation decision. But in coming to these rationales, we also found that participants were making either explicit or implicit assumptions about cessation of brain activity. And you may have noticed some of those in the previous quotes that I shared, but here's an example of an explicit assumption provided by this donor family member. I'm assuming that after circulatory death, then brain death is declared as well. So conversely, let's go over to the far right quote from a critical care physician. Here's an example of an implicit assumption. Recirculation can't restore circulation to the brain in a way that would cause that person to be alive as we understand it. So we know that stakeholders perceive NRP as an ethical post-mortem intervention. That's a really important finding from this study. But even more importantly, we also know why they think this way. In their reasoning, participants often referred to the family's decision to remove life support as the ethical turning point, the real ethical crux of the matter. As this family member put it, it all lands on me, the burden of the decision for the rest of my life. So to make an ethical decision here, we have to trust, you really have to trust the person or persons giving you that prognosis, that there's no hope of meaningful recovery. Another donor family member shared, this is a process, a trust building process of coming to zero hope and then looking for other miracles in the room. Seeds of trust are planted in that process. Once these seeds of trust are sown in shifting goals of care from life support to care for the dying process, participants described how this placed families on a trustworthy pathway to making a donation decision that ethically involved a continuum of care for the donor, for the family, and for the organ recipient. They viewed NRP as an ethical part of this care process because it fulfilled the donor's wish to donate and provided support to families in their grieving process. And this last point is illustrated by the following two quotes. So this one from a care provider sharing that we've had families that consented to organ donation for circulatory death patients. And then the patients have taken a long time to naturally pass away and their organs didn't end up being viable. The family really wanted to be organ donors and they were very upset by that. It was almost a second element of grief. And this finding was affirmed by a different care provider who observed that families do better if their intention, if the path they're setting is to successfully donate organs, then they do better in the aftermath if that donation is successful. And so anything we can do to ensure that donation is successful, we need to do. So our study has some very important implications for preserving trust in Canada's organ donation and transplantation systems. So first, trust in updated criteria on death as permanent cessation of brain function will be vital. Our study shows this. This means that there are really pressing implications for empirical research to test that assumption that there is in fact a permanent cessation of brain function. And I know there are folks on the call that can speak to us about that research that's ongoing. And then this is going to have downstream effects on policymaking for NRP. As Charles shared, in other contexts, NRP has gone ahead. One thing that he didn't share is that there's now been significant amounts of pushback and even halting on NRP for some of the concerns that have been raised. And we would argue because things were pushed ahead and done without the kind of necessary groundwork in terms of thinking through the ethical implications and asking the people for whom it matters most what they think and feel about them. Really centrally, our study shows that when seeds of trust are planted in the care leading up to the donation decision, NRP can be viewed as part of the pathway to fulfilling the gift of life. It can be seen as a caring intervention, and that's got important implications for how we conceptualize family and donor care during the dying process, as well as the care for the organ recipient. Finally, we've shown that, or given an example of stakeholder research and why it's so vital for trustworthy implementation. And our study has implications for ongoing research into a consent process for NRP that we feel should involve participatory research with folks in that center of that circle of care, if you reflect back on that, with family members, with care providers, in helping us to co-design a trustworthy consent process for NRP. So I'm going to stop sharing and leave it there and open it up for questions.
Great, thank you both for that excellent presentation. We'll now open the floor to any questions, so you can raise your hand and unmute yourself or just type it in the chat and I'll read them out loud. And if I can just start with the question that I had. So you mentioned that in the quotes, there was a lot of people that said that the decisions should be up to the donors themselves about these things. So in the process of donation currently, are donors and their families informed about these things? Like, is there a lack of information that is given to donors about, whether the heart stops and stuff like that? Or
Charles, do you want to take that one?
I was going to ask you, Mary, what was there on that, just from the interviews with donor family? I mean, how satisfied did they seem with the information they were given during the dying process and leading up to organ donation?
So if we're talking specifically about a consent process for NRP, there is not one, because as Charles shared, NRP is not yet implemented in Canada. So these are hypotheticals, but and that is why there's a need for more research in terms of what, if NRP were to be implemented, what should or could a consent process look like? So we did actually ask participants for their insights or suggestions on what that might involve, and also importantly, who should be involved. So it's a little bit more nuanced there. There were some differences, but in general, I would say folks felt that the people that are most impacted by the consequences of NRP, meaning the donor family members of deceased donors, should be deeply involved in what a meaningful consent process should look like for them. And some of those shared, and also some donation coordinators who are directly involved in current consent processes, shared that having some more visual resources, such as the type that we shared in the interviews, which were not about a consent process, but many participants, in fact, shared that even though they were well informed about NRP, and there was a variation in our participants in terms of novel versus informed understandings of NRP, even the ones with the most informed perspective sometimes shared that seeing things visually helped them kind of conceptualize the issues in a more fulsome kind of way, and really come to grapple with their personal viewpoints on the ethics. And in terms of family members, one of them shared that, which I think is really important to remember, and this has been affirmed in other studies of the experience of donor families, that making a donation decision is such a cognitively and emotionally complex and fraught time that they don't have the cognitive load to really take things in all at once. I think we can all empathize with that. And so having something like a video that they could come back to and review a few times to help them kind of see their way through the decision-making process and answer some of their questions about what's going to happen to their loved one, and what forms of care will be provided, that would be really important. But having that opportunity to both visually conceptualize and review, again, we don't have like a large sample of data there. That's food for more research, but that's certainly a signal coming out of our study that there's a need for that.
If I could just offer a brief comment, I think one additional thing that if I'm recalling correctly, we heard both from donor families as well as representatives of organ donation organizations, was this idea of that respect for persons in this context, right? Respect for the autonomy of donors and donor family requires that we be flexible with the amount of information that we're offering. That some families are going to want to know absolutely everything, every single detail about this, while others would prefer, perhaps they need less detail, right? And so the challenge to us then is to design a consent process that's respectful of the differing needs among families for the amount of information.
Yeah, that is true. That was definitely in the data.
Thanks, Charles. Thanks, Mary. What countries have NRP in their systems already? Do any countries have it, like use it, practice it? I don't know what the appropriate term is.
Yeah, so it's pretty widely used in Europe. I know Spain sees a lot of it, France, Italy, and there are some centers in the United States. We've got some people on the call here who are definitely more expert in this. Murat or Nick, do you want to sort of fill out that very brief list that I gave?
Sure, I don't have all the information, but I would say that it is practiced in all the places you mentioned, in addition to some Scandinavian countries, and it's in fact mandatory for liver donation in places like Norway and Italy, especially because they have a very long hands-off period of 20 minutes. So it's absolutely necessary for liver viability there. But I'd also add that although TA-NRP was initially used in places like France, Italy, and the UK, they've now put a pause on it while they further investigate some of the ethical and indeed legal concerns. So in places like France, they've stopped doing TA-NRP, but they do ANRP, abdominal, which is just the abdominal version, but they do still recover hearts. They just do it in the conventional rapid heart recovery mode. So
thanks very much, Nick. That was really really helpful. As I mentioned, NRP is not currently used here in Canada, and I guess there's been as a result of a lot of reflection on this, so there's been a decision to do a research rollout of only abdominal NRP here in Ontario, starting with abdominal NRP, because I think the sense is that that's the safest form of NRP with respect to donor safety issues and this theoretical possibility of reanimation of the brain. So it's being rolled out here in a study sponsored by Ontario Health, Trillium Gift of Life, to do a series of NRP cases with highly sophisticated neuromonitoring to ensure that we can demonstrate that there's no return of blood flow to the brain, nor any return of brain activity as measured by EEG and other neuromonitoring modalities. So that's kind of how the rollout is starting here in Canada. Quite different from how other countries, I think, have jumped onto this. And I'm really pleased to say that I think Canada is proceeding in a cautious and prudent way to ensure that donor safety, first and foremost, is ensured.
Are any of the other provinces considering it or looking at it from their perspectives or their provincials? Or is it just in Ontario for now?
No, we're looking at it in Alberta as well. I know just from talking to the leads at AHS and their SENS positions that is a high priority to look at over the next 3 years.
Thanks, Sean.
Thanks.
I have a follow-up question. Would there be a reason to not take this approach?
And when you say this approach?
NRP, like why is it not just standard? Like I think I'm missing something that why doesn't everyone just do it?
Right. Well, I mean, as we've heard, some countries did just sort of start to do it. And then, I think and a subset of those have sort of put their programs on hold, or at least put sort of the thoracoabdominal programs on hold. I mean, I think there, as I outlined just super briefly in my introduction, I think there are a range of ethical issues raised by NRP that need to be carefully addressed. I think for me the top concern is the issue of donor safety. The fact that we're assuming that surgical safeguards put in place are going to be adequate to prevent resumption of circulation to the donor brain, but that has just not been rigorously examined, and I think that's something we need to assure ourselves of, because that would be problematic both for the grounds on which the death is declared, I think, and also would raise questions of the reanimation of the donor brain and possibly, donors becoming aware, and we want to be really sure that doesn't happen. I don't know if Murat, if you wanted to.
I just wanted to add on first, if you don't mind.
Mary, please. Yeah.
Yeah, no, just so again, like back to the data. Like what's really important to understand from this study is that the trust, people made a lot of assumptions that a neurological kind of death had occurred, that basically death meant for everyone permanent cessation of brain function. And so they assumed that had happened as part of the dying process, as part of the hands-off period, once circulation had ceased. And so that's why it was meaningful them, so that the dead donor rule was not violated because they assumed that there was a cessation of brain activity. And so if trust were to be violated in that, so for example, if these neuromonitoring studies that perhaps Dr. Slesareth can tell us more about, if they were to show that there actually was still some lingering brain activity after that 5-minute period, that would constitute like a no-go before we even get to the surgical intervention, because I also found that not everybody understood, and I've shared this with some other physicians in the meantime in a different context, and I found that even some of them didn't understand. If they weren't, transplantation surgeons, they didn't necessarily understand that when you take a body to recover organs, you're doing that without anesthesia. So that assumes that there is no more neurological activity, right? And that assumption is one critical care physician in our study, who's a neurologist, shared. He couldn't believe that assumption hadn't yet been tested. And so this is why it is so critical that Canada has taken this cautious approach and that there is this ongoing research into brain activity. So I don't know, Murat, if you want to comment further on that.
I largely agree with you. I think we need to really think about, zoom out a little bit from the NRP aspect, because NRP really tests a lot of assumptions, I think. But let's start with the most common form of deceased donation, which is donation after neurologic determination of death. And in that particular type of donation, we confirm explicitly that brain function has stopped permanently by completing a thorough neurologic examination, by having clinical history and imaging consistent with loss of brain function. And if there are any confounders, we will perform an ancillary test to confirm irreversible cessation of brain blood flow. There's tons of data from observational studies confirming that, EEG is flat. There is no brain activity. There is no brain blood flow. There is no that this is truly a permanent irreversible event. But brain death is low, and so we're doing DCDs now. And DCDs, most of these patients would have been considered for neurologic determination of death, but they don't meet the stringent criteria, and there's some residual function. Most of that function is usually brainstem function, and but we assume when we take these patients off life-sustaining measures and their circulation stops, that brain activity stops at the same time. And that assumption is rooted in strong physiologic rationale. We know that when patients' hearts stop, when they have cardiac arrests, they fall down and they lose consciousness. How long does it take for brain activity to stop? We don't really know that, right? And we don't know what happens in the context of a progressive hypoxia and hypotension that occurs during the withdrawal of life-sustaining measures and the dying process in the ICU. And that question is being answered by the new part study, which is measuring and recording and trying to understand when brain activity stops relative to circulatory arrest. So that will be a question that will be answered empirically. We do have some preliminary data from 8 patients suggesting that it stops about 7 to 8 seconds before circulatory arrest, so that's reassuring. The third question is, once it's stopped, what is if there is failure of surgical safeguards in NRP and resumption of brain blood flow, what is the likelihood that the brain will function, will restore? And we simply don't have that data. We just don't know right now, and we don't know how safe surgical safeguards are. Now, to put it into research context, we always talk, any test you should have pre-test probability of something being true. You apply the test and then it either increases or decreases the probability. And so, is it likely that these patients will have resumption, even if there is resumption of brain blood flow, that they will have resumption of brain activity when they have devastating brain injuries that may not quite meet the neurologic criteria? No, the likelihood is quite low, and the likelihood of surgical safeguard failure is quite low, and the likelihood of collateral circulation is quite low, but it hasn't been tested. And I would, at the extreme, if you think about DCD donor, they may have normal brain function, and that would be somebody who's undergoing donation of a circulatory death following MAID provision, so medical assistance in dying. Those patients have fully functional brains, and if that patient is declared dead using neurologic criteria, put on this regional ECMO, surgical safeguards fail, or they have collateral circulation, the resumption of brain blood flow, you can be quite convinced that there will be a resumption of activity and function of the brain and potential for donor harm. So that's that extreme. Now, the interesting question that I got asked yesterday while doing rounds, and people were stopping me and asking me these questions, the nurses, they said, well, why don't we just give people anesthetics? Why are we even going through the dying process in the first place if they consent to organ donation? So I really think that what has been done here is a very interesting. NRP is a very specific technique with specific challenges, but it is forcing us to re-examine how we build trust in organ donation, transplantation. How do we maintain that trust, and who should we be involving in development of these policies and processes, right? And donor families definitely need to be involved. The public need to be involved, and I think it's in the meta conclusion of this study, for me at least, is that it's reevaluating how we think about this. We should be taking a pause, and before we even apply the NRP procedures or neuromonitoring, this is extremely important work. So I'll stop there. Don't know if that adds anything.
Go ahead, Linda.
Hello, this is a fantastic conversation. My comment is related to the stakeholder piece of the research that was done in terms of supporting the donor family. And as we've heard in this presentation, it's so complex, and the donor family is watching this happen and wondering if there's room or opportunity for additional support in systems to the donor family, in addition to the donor coordinators who are run off their feet, but someone who's assigned to that family to help them through that journey and thus build trust as well in the process, because knowledge is helpful to building that trust. But if they're watching this all happen in front of them and have periodic interactions with the decision making, those minutes become hours in their mind. And is there an opportunity to support them? Just a thought, it's additional resources, but maybe it would help build trust in the system.
I'll speak to that just briefly, and then I see some other hands went up. I don't know if there are comments or different questions, but
actually, I was going to add just exactly on the same topic as Linda, so you could probably address both at the same time, and that has to do with potential donor family turn down. Because of the complexity of information presented, our programs actively, with histories in NRP, UK, and others, seeing a different turn down rate compared to standard organ donation approach because of the complexity of NRP or because of the ethical considerations around that complexity.
There were some signals in our data, and I think there is a recent kind of Canadian survey of donor family experiences that also have some signals about that there's some turn off that donation pathway because of the wait time and really what's an agonizing process of watching your loved one die. And then the uncertainty, there's a quote, not from our study, but from the other Canadian study of a family member of a circulatory donor, deceased, well, they intended to be, right? And just kind of like, what do I do? I'm thinking about, I want this donation to go ahead. Please let them die. Well, wait a second. This is my loved one. Like, don't let them die. Like, they're in this agonizing place. So it can turn people off the pathway. Another person described just being left alone at the end of it and feeling completely like lost and alone. So it's like, yes, care during the process, and social workers and spiritual care providers may be available in some settings. Can we make that more of a consistent provision of care along with the critical care team? But there's needs for post-care, post-donation care as well. Murat?
Yeah, it's a great question, Linda, and Sean, great comments. I think first of all, I want to acknowledge that organ tissue donation coordinators do a lot of work and support. They're not just coordinating tests; they spend a lot of time, and I know this because I speak to them through these cases, and it is heartbreaking a lot of the times, right? And then they're special people, organ tissue donation coordinators, especially when they stay and work for so many years, right? And so to be able to move the challenging cases like this forward, address all the logistical challenges in our healthcare systems, pre-COVID, now post-COVID, and the deal with the mistrust and the booking of the ORs and the delays in the system, and still maintain that thread of trust with the family and support them. I mean, I think that's a category of stakeholders that we need to focus on and learn from and learn anecdotes and extract those anecdotes from how do they keep, in my opinion, donation in the current state in Ontario, donation, how it's continuing to work is I don't know, to be honest, because the case length has increased significantly. And you can imagine the families accepted death of their loved one, and now they're stuck in waiting for the actual donation to occur. And they're initially giving 24 to 48 hours, which would become 72 hours, it becomes 90, and so on, right? It just keeps, the timeline keeps moving forward. I don't think the timeline moving forward is intentional, but it's just a reality. But how do you keep folks from pulling away the consent? Now, that being said, I think the idea of additional support for our coordinators is interesting. The idea of support in post-donation period is interesting. But I would actually go and say, and zoom out a little bit and say, what does good donation look like from the perspectives of families who have who went through this process and had both good and bad experiences? And generally speaking, who we tend to hear from are people who have had good experience, either who have consented to donation, the families, and have had good experience. We rarely hear from people who had bad experience, pulled away their consent, or never consented in the first place because it was just too overwhelming, complex, long, and whatnot. So I don't know how to address that methodologically, but I think that needs to be looked at. And I think organ tissue donation coordinators in this kind of in that line of work shouldn't be advisors to, not just they need to share their stories. You know, it looked like they're going to consent and people have withdrawn and stuff. So unexplored territory, and I hope I hope that Mary will get interested in this, because there's so much to uncover, and you can't do this with surveys. This is not a survey type of work. This needs proper qualitative approaches, and it's great to see this happening.
Thanks, Murat. I think, yeah, the donation coordinator's role was an emergent finding in the study that we weren't necessarily anticipating, and it was a thread that we began to pull, and it needs to be explored further, because again, that's that thinking about conceptualizing NRP as a continuum of care, and also like nested circles of care, and really thinking about who's most influencing whom. Donation coordinators are right at the center of that circle, but they're also interfacing with the donation systems. And so I think there is so much from the system to learn from those people. And I noticed that because they're interfacing with both, they see the needs in that kind of like more zoomed out picture. So they see the pressures on the hospital systems as well. So they're really kind of linchpins, I think, in the system that we need to explore and get their, value and learn from their insights. I think I saw a couple of other hands up.
I see there's a comment in the chat. Maybe I can read that one out loud. So it's from Heital, and they say, great presentation. May I ask whether there is a standard assessment or surveillance on an irreversible cessation of circulatory and respiratory functions? And then there's a comment that says, as I have heard one report, some critics of CDCD have asserted that such donors are alive at the time of organ recovery, since circulation can be reestablished after 5 minutes of circulatory arrest, so it is not irreversible. In a counter argument, it is argued that if there are no plans to restore circulation, the patient is dead, even if potentially reversible.
So I will let Murat speak to the technical question about how circulatory functions are diagnosed as being irreversibly. I think there's a problematics of the language of permanent and irreversible that our study helped to uncover, because we asked kind of those questions about, is the dead donor rule violated, which is essentially what the person in the chat is asking. And participants, again, across stakeholder groups, across novel versus informed perspectives, explicitly or implicitly went back to two things. First of all, that the family had made a trustworthy decision. They built trust in the decision to withdraw life-sustaining measures and begin a process of dying, because they knew that there was no hope of meaningful recovery. And so when we get past the semantics of permanence or irreversible, the question becomes, is there a chance of a meaningful recovery? And the families have ethically decided that no, there isn't. Otherwise, they would not remove life-sustaining supports, right? The other issue was that everybody was making an assumption, real or perceived or explicit, implicit, tested, untested, that a permanent cessation of brain function is what has in fact occurred or what should occur, and that the restoration of circulation is really becomes a bit of a moot point, because the trust stopping question, the critical question, is what's happening with the brain, because it's the brain that causes the heart to beat. So I hope that answered your question, but that's certainly what came out of this study.
I can just add on to that briefly. I think it's really essential for the ethics of NRP that Canada now has a unitary definition of death based in the permanent loss of brain function. That's really key to NRP being able to proceed in an ethical fashion. So there are, I mean, as I understand it, there are sort of two pathways to the permanent loss of brain function. One is as a result of a primary injury to the brain, and the second is through the loss of the heart beating or the lungs being able to breathe, such that there's a lack of circulation to the brain, which leads to a permanent cessation of brain function. So NRP doesn't raise sort of the problems that were suggested under that unified definition of death, because the circulation to the brain is isolated during the NRP process, and the restoration, the artificial restoration of circulation regionally within the body does not lead to restarting circulation to the brain in NRP, right? I mean, it's part of what we need to confirm empirically through our studies, but that's kind of why NRP does not violate the definition of the unified definition of death in Canada. It also explains why countries that don't have a unified definition of death that centers on the brain have problems with NRP. So in the United States, there are two distinct definitions of death. One is brain death and the other is circulatory death, and they're separate. And so NRP in that circumstance plainly involves a restarting of circulation. And under that regulatory regime, that undermines the very basis on which death was declared. So south of the border, they have a real problem because of their lack of a unified definition of death. I hope I got that right, Murat. I'm looking at you. Okay.
That was great. Yeah, it's perfect.
Okay, that was an excellent discussion. I see that the time is just about up, so I'll just wrap up the session. So I just want to say thank you to everyone for your questions and comments throughout today's presentations, and doctors, on behalf of CDTRP, thank you again for presenting. And if anyone has any additional questions, comments, or suggested topics and speakers, you can contact Erica Croft at ekcroft@cdtrp.ca, and I'll just send her email in the chat right now. And I want to mention that all participants will receive an email asking them to fill out a survey, and we would appreciate it if you took 3 minutes to complete it. So thank you, everyone, and enjoy the rest of your day.